Hi. This will be live streamed on the DSS YouTube channel and then recorded. And then let me share my screen. Again, if Susan, I might ask just because I can't always see folks with their hands up
on the DSS YouTube channel.
Hold on. Let
and
me
then record it.
So we can't hear.
And then let me share.
Okay, great. Sorry, that was me on the YouTube channel, everybody, in case you need to hear me again. Okay, can everyone see this deck? Okay, great.
Yes, I can.
Excellent. Oh, actually, the pictures are showing up. Great, I actually can see folks. Lovely. So welcome. The commissioner was actually hoping to join, but she got pulled into something. So she just wanted me to send her regards. And again, appreciate everyone being present. Today, we have a pretty streamlined agenda and excited to be able to actually show you, or Susan will be showing off a dashboard demonstration of something that's still draft, but live, and you can actually, but real, and we'll be clicking on it, and that's exciting. And we'll be looking for your feedback and comments on that. Additionally, after that, we're going to be going through, as we discussed last time, the OHS quality benchmarks, and Deepti and will be kind of running that for us as we get there. So I do think we'll aim to keep this at an hour today, just given that agenda. But please feel free to ask questions and such as we go along. So again, the big one is here. What we'll get to is the dashboard and then the quality benchmark. So just as a reminder, kind of our revisions to what we're launching in phase one is really this kind of minimal viable product of a static quality measure that's going to be directly from our ASO partners for now. Static, potentially dynamic financial data, but probably static is what we're thinking initially, and then some dynamic eligibility data. That will be kind of phase one launch. And actually, we're already almost ready to jump into the dashboard demonstration, which I am very excited about. My computer may have frozen here. Oh, there we go. Sorry, everybody. And we're going to be looking for your initial feedback, thoughts on format, structure, opportunities for improvement. Again, this isn't ready for prime time, so this isn't a link we can send you at this time, though in the future, we hope to be able to, we'll just kind of walk through it. I'll help monitor for questions, but we should kind of make this discussion. Susan's going to walk through it. She and Krithika Deepa, who's head of our IT group, I don't think she's on, but have been working diligently to get this off the ground. So Susan, I'm going to turn it over to you now. I know you're going to try to share your screen, which you should be able to. Let me know. I'm going to stop sharing mine for now. Okay. And as you pull that up, again, noting that we have to refine some of the data on this still. So again, if you took a screenshot and then like put it up on YouTube, we'd say, well, this data is not ready to be accurate. So I'm just saying that out publicly. But we wanted to show you kind of what this dashboard hopefully eventually will look like. Again, looking for your expertise on feedback, thought on things. So Susan, take it away.
Sure. Are folks able to see?
Yes.
Yeah.
Okay. So just to reiterate what Brad said, that this is still a draft. This is really kind of a proof of concept. We were developing this with an eye towards an expanded enterprise dashboard presence and experience. What we try to do here, which is very exciting, and I can actually send people a link to this, and I think some folks may be familiar with this, is trying to put into an electronic format our People Serve report. So if anyone has accessed that report, it's a good 300-400 pages. So it provides data related to our programs and services, broken out by key demographics at a statewide level as well as a town level. So really what these 10 or so tiles are able to do is to actually move the entirety of that hard copy report into something that allows people to manipulate and to filter as they may desire. This is still on the development site, so I can assure you that it's going to be sluggish, that there may be some lag. I don't, someone could be, other people could be on it, working on it. So there may be some other little hiccups. So I don't want you to necessarily judge the product by some of that, because this is still very much, being tested. And there's work that's happening really on the back end piece of it. So those things that I know I've talked about at prior meetings about making sure that the appropriate firewall is there, so that there's no way that these data can be accessed and obviously jeopardize the privacy and confidentiality confidentiality of our clients. Also those pieces related to ensuring that we have the appropriate server capacity and the load balancing to obviously support the demand that we think and hope will come when we make this live. But I'm very, very excited to share this with you. And as simple as it looks, it has taken some doing to kind of get here. There are things that we know aren't correct here. So when, as Brad said, if you take a screenshot and share the numbers, we're going to disavow it. We know that there's some things that aren't quite right, in terms of like, for example, there's the tile related to race ethnicity. First, there's a typo there. And also that this is, as folks who may be familiar with some of the data that we presented in the past, we've really, for the most part, just been sharing our data in terms of race discretely and then ethnicity separately based upon the OMB standards. Looking at the Public Act 2135 and how other entities, other state agencies present their data, which is also kind of that race ethnicity combo, which kind of rolls up Hispanic of any race into the variables. We thought that would also be another slice that might be helpful for folks, to look comparatively. So this is kind of new for us. And so there's still some work that has to be done. So the numbers don't quite make sense when we click on certain things. So we know that particular tile really does need to be updated, but we do think that that's going to be a nice enhancement and will align us with other agencies and other entities that often do show some of the race and ethnicity data as a combo. So I think that will allow folks to kind of look at that data in relationship to other things. So first, what you'll see is that you'll be able to filter by dates, so annualized. So this goes back to 2021. To 2011. There'll be some caveats. So, there's some narrative that we'll develop for this, user guides and things like that will help to explicate kind of how to use some of this, and that there were certain changes over time with some of the data. So people know that from this period forward, the data may look different, blah, 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 blah. So kind of those things are going to happen. And if you then click on this, conceivably, you should see that the numbers just updated. So that if you pick 2021, all the tiles are going to or should correspond to that change. So there may be a couple. I think there was one tile where we thought wasn't responding appropriately in some instances, but again, changing this, should be able to. Again, may take a minute for those numbers to accord. I'm not gonna, there's actually kind of an animation feature that will kind of sequence so that folks can see across the years. I'm not sure if that's gonna work, but you can kind of play forward or play reverse. So it should be updating. So it is working. So those numbers will update for each as the years kind of go forward. You'll see the numbers update if somebody just kind of wants to see some of that growth and change. So this is bringing us back to 2021. You're able to then you can click on a particular county and the numbers will update accordingly. Okay. And I shouldn't have expanded it, but if you click out, it will take it back to all the counties.
Do we have a hand up, Susan? I was going to say.
Okay.
You want to jump in?
Yeah, I do. Hey, Susan, thanks for a great presentation. I don't want to focus on the individual numbers at all, but as a broader point, this data is coming from, I presume, multiple agencies or multiple different programs. Is there any way to harmonize this? For example, if there actually are people that have unknown race, is it possible that they have a known race in another program? Or across years? Have we thought about which programs are the gold standard for some of this data?
Yeah, that's an important question. And I'd have to look a little bit deeper than with some of that. But conceivably that this is kind of a singleized client level data set that is then taking it. So I could be wrong, but I will confirm with Krithika and this that hopefully that data that's coming from any of the potential programs that are listed there, that information is being updated. But obviously the piece that I would have to just connect on is kind of what's controlling, so that you may potentially have conflicting information for a variety of reasons. There could be error. Someone could have inputted something inappropriately, or some other or some other thought, something else could have actually, occurred that may have compromised it. So that's something we can certainly look into to see if that, what that is. And if not, that certainly can be something that we can look as an enhancement to figure out how to express that golden record concept.
Yeah, it's completely plausible that this is like version 2.0 or 3.0
Yeah.
or something like that.
Yeah.
And I'll
Absolutely.
just, the other thing to point out, just Susan, if that's okay, and I think related to that is, if you look at race, you see 167,000 unknown. I think in a lot of our data that we publicly reported for Medicaid and CHIP, we're closer to 30 to 40%, which means, again, what's the kind of coming back to what you just said, like, is there a Trump, is one program, do we have more information, say in SNAP or something that we're unaware of that's actually making it look like this? So this is where we need to get a little bit more granular to understand before we can put this out publicly. Because that obviously, but it also is helpful to know, oh, do we have more accurate information elsewhere that we should be trying to combine? I think, Kim, as you know, we haven't historically combined this information together. And so maybe important things for us internally to start doing as well around this issue.
Yep. So it's, very much a, work in progress, and, and I absolutely appreciate, other lens and other thoughts about how we can obviously improve this. Also this would allow for, unpacking at a town level. One of the areas that I think wasn't updating quite properly. Okay, well, the state count was doing that. And then the number should accord appropriately. Again, there's still some hiccups on some of this. So, if I click on something and it doesn't quite act right, it could be a little sluggishness, or it could also be, kind of, operator error. So I will take the hit on that. So conceivably also is that by clicking on a particular group, this allows for effectively kind of your cross tabulation. So obviously this updated on that statewide level. So we need to just make sure it's going back to that town level, doing that. So, those kinds of pieces of allowing for making sure that the filtering is happening at the level that we would expect. But conceivably, again, when we're talking about picking a particular group, it should allow for that cross tabulation so that information is representative of the particular filtering of each of those particular demographics that you're choosing, and then that the program data would also update accordingly. One of the things that we do know we need to add is the breakouts by the actual health plan types. So we need to kind of add that into one of the tiles here. Also, I'm having conversations about some ways of supporting some translation so that that folks who may not be English proficient have some ability to also access these. So we're looking at what we might be able to do with that. I mean, I know that Google Translate isn't always the best, but that may, potentially be something, at least in the interim, that we could potentially explore to include, so that there is at least some access. This is very much, intended to be kind of iterative in allowing us to, and we'll be adding other programs across the agency as part of our dashboarding environment, so that there are things, that related to child support that obviously aren't reflected here. There's more detailed data about social work and other things like that, our quality assurance. So we're working with those, and of course also some other things related to our community based services. So we're working with the divisions across the agency about data that we would also want to include, if not specifically on this. But potentially also on some other type of separate kind of dashboard presence, but really this kind of kicking off our public facing external dashboard. I see Ben, you had a question.
Yes, thanks so much, Susan. This is very exciting. Just a quick question, since this is what we're seeing here is cross-sectional data, but then again, a lot can change over the course of a calendar year. I was wondering how, as it's currently constructed, how you might assign someone as, let's say, less than age 1 versus 1 to 4, given the fact that might change over the course of the calendar year, or for that matter, where their address is and so on. Where do things where does the cross section happen?
Yeah, we did include 2021, but the intent is really to make this annualized, so that so that if it's going to be kind of like, if we are publishing things that are in advance of kind of the end of the year, it's going to be kind of where they are at that time. So you will see some of that shifting, but the intention is really to kind of make these kind of annualized. So we'll at the end of the year be based upon kind of.
Oh, I may have lost Susan for a second. While she's coming back, yeah, I think Ben, you raised a good point. Those, when you get enrolled in the program, is that the information that we're seeing, and it's how are we updating it on a live basis in terms of age group, or is that upon enrollment? Some of this information, I think, over time we're going to need to. This is where we need to put more information on here about what exactly this represents. Susan, are you unfrozen?
I don't know. You tell me.
Yes, you are. Yeah, we can hear you and see you. Okay.
Okay. Yeah, I got something that my connection is unstable, so I don't know what's going on with that. So I apologize in advance if I start looking like Max Headroom. Some of you young folks may not know that, but some of you older folks know what I'm talking about. So that's a question I will need to just follow up to make sure that, we're clear on that and have that, appropriately documented as to kind of what that, kind of how that age bucket is constructed and how it can ultimately be utilized. I know that we are ultimately trying to think about this as kind of, some of these data is kind of annualized, but obviously I do want to make sure that we have documentation that makes clear what each of these variables, the data represent and whether or not there's any duplication or unduplication and all that kind of stuff so that folks can make sense of this on their own as best as they can. Kelly?
Hi. So just echoing Benjamin and others, this is very exciting stuff. And I know it's still in progress, but the potential of this is excellent. So thank you so much, Susan. I had two quick questions. The first one is for the statewide count, and I guess that kind of trickles in with everything. Is it based on people served, or is there like double counting depending on if they're like in more than one service? Or
yeah, it's active. It is the count is active. I don't quote me on that. I think there may be some duplication on that, but okay. I do want to follow up on that. But I do, as I understand it, I think that there is some inherent, duplication of that across, programs, because it is based on active participants. So I do want to just make sure I'm clear on some of that.
Okay, thank you. Yeah, and my other question is, can you explain the difference between the block that says race/ethnicity and then the separate race and ethnicity boxes?
Sure. So absolutely. So the race ethnicity, the separate tiles are looking at race and ethnicity just discretely, so that regardless of your ethnicity, this is the race bucket that someone hopefully has self-identified to put themselves into, and then using that OMB standard of Hispanic, yes, no, and then and if you are Hispanic, what ethnicity of Hispanic do you identify yourself as? The combo box is meant to, and it's definitely not working correctly, is meant to kind of roll up Hispanic as kind of quasi race. So a lot of times when you look at race ethnicity data from a number of entities, often other state agencies, you'll see that kind of Hispanic is treated as kind of its own race. And so that regardless of so if a person says, I'm Caucasian and I'm Hispanic, yes, the race ethnicity combo would then say, okay, regardless of whatever race you're identifying as, but if you say Hispanic, we're going to bucket it as Hispanic so that you can kind of see that different lens of it. So it's allowing folks to kind of see different swaths of this. And so that they're not needing to necessarily kind of try to do that math from race to ethnicity. Because sometimes, when we're looking at data, and we'll sometimes see certain things, and they'll say, okay, well, this is, it's X%, kind of, Caucasian. And I think that for many folks, they're not necessarily viewing that Caucasian as potentially being inclusive of folks who are Hispanic and who may have a, kind of a different experience and different kind of trajectory with certain things or different access points. And so this is another way of allowing us to get underneath and better understand access, utilization and experience in different ways. So that's kind of really what those three are representative of. So it's allowing folks to kind of choose what slice of race and ethnicity it makes sense for their particular interests.
Thank you.
There are a couple hands, so I don't know who was up first.
Karen and then Ann.
Yeah, I just wanted to echo what others have said. I think this is really promising, and thank you for sharing it. And I had some similar questions to the ones that Kelly was just asking about, kind of what the assumptions or rules are that went into the data, right? Are you looking at an annualized monthly average or something, you know, or total? And I think there was a technical specs document that was attached on the open data portal, and maybe, you know, to avoid us constantly asking you those questions, it might be helpful to just link that here so we can reference it.
Absolutely. Yeah, no, you're absolutely correct. The intention is to, you know, is to ensure that those guidance and meta documents are available. So absolutely agreed.
Anne?
So I have a very quick question, Susan. So this is again awesome and great. And again, this may be probably somewhere else in it, but so one of the things I always kind of am looking at is trending over time. So this is a year, right? And is there ability to see this kind of either components of it or the whole thing, like, you know, number of, you know, the statewide count over year. I know you can pull up each year individually, but then, so for me, then I would put all that into a spreadsheet so I could see it over time. Is that something that we're planning on doing? Is that something that is needed, or is it just, do you think, enough to have the whole year here? I ask it more as a question.
No, I think, you know, some trend information probably would actually be beneficial. You know, I think, again, you know, those are all things that, you know, we can and should be looking at for future phases of this, you know. So I don't, you know, think of this as kind of being, you know, it's done, you know, like this is it, you know, knock yourself out and, you know, walk away, you know, drop the mic, moonwalk off. I do see this very much as, you know, this is just kind of an, you know, an initial, you know, again, more it was starting as kind of this proof of concept and really trying to get tight on some of those back end pieces. I don't, you know, I'm not sure that, you know, a lot of other state agencies have necessarily kind of looked to publish, at least within Connecticut, have looked to publish Tableau data forward. So there's been a lot of that, you know, technical work that has had to happen, as I stated before, in terms of some of that firewalling. So, you know, that's been, you know, really a big thrust of this. But certainly in terms of the front facing aspect of it, I think very much that we want to think about this as something that continues to grow and is meeting the needs of stakeholders and users. I really think about this as part of a continuum. So, you know, I'm kind of very big on this concept of kind of data democratization. And then I've been really thinking about this as kind of, you know, that part of that, you know, we make reports available. You know, we have dashboarding, we have the open data portal, we have folks who are able to request data for research, and that, you know, this, you know, needs to kind of have its place on that continuum that allows people to do, you know, a certain level of self-serving, and I think, you know, some of that trend data, you know, things that can be exported out from here that will allow for, you know, some, you know, manipulation. Obviously, you know, that would not allow for any identification, needs to be, you know, part of future enhancements and expansion of this.
Okay, great. Thank you so much.
Thanks, guys. Appreciate everyone's feedback. Susan, anything else you want to highlight here?
No, this is, you know, that's, you know, again, this is still very much a work in progress. You know, we are, you know, very excited to, you know, kind of have something that, you know, that kind of is, you know, real, feels real. But I very much look forward to, you know, thoughts about this. So, you know, if you're like me, kind of afterwards, other questions or other ideas may, you know, pop into your head. So please feel free to send an email to me, to Brad, and we will definitely, you know, take a look at it and also work with our IT folks about what we, if there are any enhancement, any things that we can do presently, or, you know, how do we stage it for future updates.
Great. And again, I just want to thank everyone for their feedback and our initial comments. And I know there'll probably be more as we actually get to launch this, and you guys can take a closer look at it in the future. And so we are hoping to have something up in, I think, January that we can put out there. That's kind of our goal as of now, that you can then access yourself. So again, thank you guys already. We look to you for feedback to improve this, again, iterative, as you know, this was a phased approach, and we will continue to need refinement, which will look to you for your expertise. Let me reshare my screen here. Okay, great. Can everyone see that again?
Yep.
So anyone, if you want to send us feedback written in the future, if there's anything that pops in your mind, you wake up and you're like, I really wish they showed us this X thing, and said like state trends over time, right? Like that's super helpful. If there's other thoughts, welcome that. And at this time, I'm going to turn it over to our OHS team. Kelly and Deepti are here kindly to walk us through kind of the process we started to outline last time in terms of the quality benchmarks. We're getting feedback from this team in terms of what is being done on the OHS side. That's the Quality Council has already kind of made recommendations. We want to feed those recommendations on these statewide quality benchmarks that for Medicaid specifically back to you to get your reaction and response if you have any. So I'll pass it over to you guys. I'll help drive it on my end. So if I do a poor job of driving the slides, that's on me, not on them.
Thank you so much, Brad. So for folks that may not know me, I'm Kelly Cinco-Stuber. I'm the Director of Healthcare Innovation at the Office of Health Strategy. I'm going to kick us off here and then pass it off to Deepti, one of our consultants who's been an excellent resource. And I'm sure when she talked at the last meeting, you found her excellent. So so as was discussed at the last Transparency Council meeting, just as a reminder, there's 4 initiatives outlined in Executive Order number 5. There's a cost growth benchmark, a primary care spend target, a data use strategy, which we're going to have a data vendor come to help us get cost growth mitigation strategies and things like that. And finally, the quality benchmarks, which is what we're here, as Brad alluded to talk to you about today. The quality benchmarks are going to be applied to all public and private payers. They'll become effective this new year, this coming January 1st. I'm sure Deepti will talk a little bit more about that later, but we are sending out notifications for the 2022 benchmarks this week. So the 2022 benchmarks have already been set and they're basically on baseline because we know that since we're only notifying them in the month of December, we thought it was fair for Medicaid and commercial and Medicare that we at least not make any huge changes. So it'll be baseline for 2022. And as a reminder, our Quality Council has met monthly since June to develop recommendations for the quality benchmark measures and benchmark values. And so what we want to do today is share with you some of the Medicaid values that we have recommended from the Quality Council and get your feedback and make sure you support our recommendations. So with that, I'm going to turn it over to Deepti.
Thank you, Kelly. And we can go to the next slide. So this is a slide that we didn't share with you explicitly at the last meeting. And I think it would be helpful to level set the types of considerations and trade-offs that the Quality Council made first when selecting quality benchmark measures, and also then to inform the quality benchmark value selection. So these were the guiding principles that the council used overall. The first is making sure that the measures align with state health priorities. The Quality Council, when it was developing its core measure set, went through and did an assessment of various state health priorities using data from DSS, OHS, DPH, and a number of other agencies to think about what are the most pressing issues facing Connecticut. There was also a focus on health equity. The council wanted to make sure that health equity was incorporated into the quality benchmarks, and also wanted to make sure that the measures that they were selecting had demonstrated opportunity for improvement. So we did not want to draw attention or place limited resources on measures that were that had high performance in Connecticut. 3, we wanted to make sure that there was alignment of quality efforts across a number of different quality efforts in the state. So the first I mentioned, OHS's core measure set. This is an aligned measure set that OHS maintains on an annual basis. And then the last 2, all of you know intimately well, the DSS's PCMH plus measure set, as well as the quality transparency strategy that's as part of Executive Order 5. The 4th principle, we were trying to strive away from topics that are already receiving a lot of attention from national entities. So I think a good example here are readmission measures. We had a lot of conversation around whether we should include readmission or hospital-focused measures given current Connecticut performance and room for improvement. But we ultimately recommended against adding such measures because data are publicly published through CMS and a number of other initiatives. So we wanted to make sure we were prioritizing areas that may not be as what's the word, popular as other topics. Fifth, and this is really where we had to end up cutting a few measures. We wanted to make sure performance could be available by advanced network, which OHS and the Quality Council view as critical entities for improving cost and quality. So this limited the scope of measures that were really available. We initially started with a broader net, and when we realized that we only had data for what statewide performance was, we thought that was a big limitation because it didn't allow us to drill down further and think about strategies that we could implement that would really drive improvement. Sixth, as indicated in Executive Order number 5, the measure should be applicable for all public and private payers. So that are measures that could be used for the commercial market, Medicaid, and Medicare market. We purposely did not include measures for which data were only available for one of the 3 markets. And finally, we wanted to make sure that data were available and could be accessed in a timely fashion. So we limited our measures to ones that had data sources that were produced annually, and we wanted to make sure that there wasn't a significant lag in when data were available. So for example, if we were looking at performance for 2020, we wanted to make sure that data would be published by 2022 at the latest, but ideally 2021. Let's see, we've got a question. Go ahead.
Hi, thanks. This is helpful context. Could we go back for just a second? I wanted to ask for a bit of additional context around 2 of these. Starting with measure number 6, does this inherently miss things like measures around postpartum periods and the quality of maternity care and the like, where we've known there have been a bunch of or large kind of structural inequities, right? Like, is there? I wonder what this mandate leaves out, just as a matter of kind of mechanics. I can stop there. I can ask my second question now, whichever.
Let me address that, and then we'll go to your second question, so you can also follow up if I haven't sufficiently addressed your question. This is challenging, as I'm sure you know, with any quality effort, is the trade-off between how do we make sure we're being comprehensive while also making sure there's a limited number of measures so that there can be targeted efforts to try and drive improvement. So I think ideally, if we wanted to be able to address all of the priorities that we had in mind, we'd have a list of maybe 15 or 20 quality benchmarks. And we really tried hard to limit it to far less than that, because we wanted to make sure there was attention and resources that could be developed and focused on a small set of measures. So we ultimately ended up with 7. There are some gaps in the quality benchmark that the Quality Council has already identified, and that the Transparency Council has also identified, and some of the that come to mind that you mentioned. Maternal health is one of them, oral health care is another, and opioid use is a third that's been mentioned by the council a few times. So we have kept our attention on these gaps, and we are making sure that when we go back and do a review of the core measure set, that we are prioritizing areas that we haven't been able to prioritize with the quality benchmarks.
Yeah, no, I agree. There clearly a set of trade-offs that need to be made. It is the case, however, that a selected set of measures could potentially give a misleading picture of where we are and where we stand, right? Like, there's a version of this where we actually start with measures that have been shown to have disparate outcomes, or to be associated with this. But I get it. I agree. I think that's a consideration number and in terms of figuring out how to streamline the vast amount of available material. As it relates to item number 5, I would have thought that you guys would go the other way, right? So there are a number of measures that can be derived almost exclusively from claims, such that you're not kind of penalizing places that have less advanced systems and the like. Can you tell me a little bit about? I don't actually know that much about the advanced networks here in Connecticut, but can you tell me a little bit more about the kind of context behind that?
So ideally, we wanted measures that could, and this slide may be a little bit too simplistic, but we wanted to be able to report performance by advanced network, by insurer, by market, and by state. And so those are like the 4 drill down areas that we wanted to prioritize. In terms of data sources, claims data, we agree, are easier to use and to calculate, and I'm sure the advanced networks and the insurers would love if we selected only claims-based measures. The challenge there is that the claims-based measures really can't measure outcomes in the way that measures that use clinical data can. So we tried, again, to create a balance between measures that rely solely on claims and those that rely on clinical data. So we purposely included, and we'll get to this, I think, in a few slides, our phase 1 measures include 2 measures that rely on outcome data. And we wanted to push those to phase 1 to allow for time to work through exactly what you mentioned, challenges around collecting and reporting clinical data. If we push that to phase 2, then we really wouldn't have as much experience or on the ground feet to try and work through some of those challenges. We are limiting, at least in the beginning, advanced network reporting based on which contracts insurers already have with advanced networks. So for example, if there's an insurer that is already using controlling high blood pressure, that's one of the outcome measures that we selected in a contract with a provider, we would have them report performance for that entity. If an insurer is not using a measure in a contract with an advanced network, we would not require them to report performance on that measure. So we're hoping that by focusing on measures that are currently in use in contracts, that would help ensure that availability and accuracy of clinical data is a bit more advanced than if we just got data from everyone. Does that make sense?
Yeah, thank you.
So moving on, we wanted to take some time to explicitly thank all of you for the feedback that you raised at the last meeting when we were discussing the measures at a high level. And part of the reason why we wanted to show you the guiding principles is that we couldn't adopt many of your recommendations for the quality benchmarks because they didn't quite align with the guiding principles that the Quality Council had set out in the beginning. I mentioned a few of these. Oral health measures was one that was raised, but unfortunately the data that we currently have for those measures are specific to Medicaid and therefore couldn't be applied to the commercial and Medicare Advantage markets. So we have kept track of your recommendations, and we've got a running list of things that the Quality Council will revisit when it returns to its core measure set in 2022. And we will be taking your recommendations into consideration when we undergo that review cycle. So I want to let you know that your feedback has been heard and we are taking it into consideration. We just unfortunately can't implement them for the quality benchmarks just today. In terms of the measures, we have 3 measures beginning in phase 1 and 4 in phase 2. In phase 1, asthma medication ratio, there are separate benchmark values for the adult population and the pediatric population for this measure. And then the 2 outcome measures I mentioned, controlling high blood pressure and HbA1c port control. These are measures that will go into effect January 1, 2022. The phase 2 measures, there are 4 of them, 3 of which are your quote unquote more traditional quality measures that can be applied at the advanced network and the payer level. And the last one, obesity equity measure, that is a statewide measure that looks at inequities in performance by race ethnicity. Now, delving specifically into quality benchmarks for Medicaid. So when the Quality Council was reviewing how to set benchmark values for each measure, they did a few things. One, they looked at current performance. So what is Connecticut's performance by market in 2019? And then tried to strive to create a benchmark value for 2025 that one, both motivated meaningful quality improvement. We wanted to set a benchmark that was aspirational, that would really try and drive change. But at the same time, we wanted to set something that was reasonable and that could feasibly be attained in the next 3 years. So while it may have been fun to go around and say 100% for everything, that's just not reasonable. So these were the two things that we were trying to balance as we went through. As Kelly mentioned, 2022 benchmark values are the same as baseline rate, and that's really to make sure that payers and providers have sufficient lead time to think about strategies to improve performance before we actually measure them against targets that measure improvement. And specifically for this meeting, we would love your feedback on the quality benchmarks that the Quality Council recommended for the Medicaid market. We'll start here with phase 1 measures, and I'll review each of the measures individually and then pause for feedback. So asthma medication ratio, as I mentioned, there are separate benchmark values for the pediatric population ages 5 to 18 and for the adult population ages 19 to 64. So current performance for the pediatric population is 66%, and the Quality Council recommended a 7 percentage point improvement to 73% by 2025. For the adult population, current performance is 63%, and the Quality Council recommended, again, a 7 percentage point improvement to 70% by 2025. I will pause and quickly note here that for this measure and for really most measures, the Quality Council looked at where current performance was, tried to find something that would motivate improvement and was reasonably attainable, and then set similar improvement targets in an absolute value by market and by like measure. So as you can see here, the 7 percentage point improvement from 2022 to 2025 is the same for the pediatric and adult population. And you'll see it's parallel in the commercial market. So they also recommended 7 percentage point improvement for the commercial market for their pediatric and adult measure. For controlling high blood pressure, current performance is 61%, and the quality benchmark recommended 68% as a target. There's also a 7 percentage point improvement component to the benchmarks for the commercial market as well. And finally, HbA1c control, current performance is 37%, and the target for 2025 is 33%. This is a measure where a lower rate indicates higher performance, so that's why the 2025 benchmark value is less than the 2022 benchmark value. We've included in the last column a reference for where the 2025 benchmark value aligns relative to national performance. So you can see where we are striving to go in the next 3 years. So I will pause here. The next slide includes benchmarks for the phase 2 market, or phase 2 measures. But before we get there, we'd like to hear from you on these benchmark values. Karen.
Yeah, I just wanted to take a step back for a second and ask what the overarching goal is, right? So I think of quality measures, and particularly cross-payer quality measures, as being a way of benchmarking whether or not we're transforming our health systems and improving outcomes in the ways we intend to. And it's not clear to me how these measures show us that, particularly given the concerns around what the asthma medication ratio really tells us, right? It could mean that kids are have multiple households more than anything else. And I also know that the goal was to center equity in this work, and I'm not sure how a universalist approach to any of these pieces would promote equity. So I'm just curious to hear your thoughts on kind of a more strategic, higher level of how these will help improve outcomes in Connecticut.
Yes, so I'll try and address your multiple points. Please feel free to poke me if I've forgotten one of them. So in terms of the health equity component, I think ideally what we would love to be able to do is take performance for all of these measures and stratify by race, ethnicity, language, disability status, sexual orientation, gender identity, et cetera, et cetera. The challenge is that we do not have data on that front today. We also have thought about whether or not we would have a quality benchmark focused on, for example, data completion or collection of such demographic information, but we do not have enough, a robust measure that we've developed that we could implement for the quality benchmarks right away, or an understanding of where performances at the advanced network level, at the payer level, and at the market level to be able to set reasonable benchmarks for 2025. So when it comes to addressing health equity, the way that it was most, I would say, readily feasible for the quality benchmarks was through the obesity equity measure. But the Quality Council does want to do more with it, and we're exploring the types of measures that I've mentioned: data completion, stratification of performance by race, ethnicity for the core measure set. And that is a priority that we'll return to in 2022. For the asthma medication ratio measure, we agree that there, and we went back and forth on this over maybe 3 or so meetings, of whether or not we should include the asthma medication ratio, since it does perhaps, it looks at the ratio of controller medications to rescue medications, which, as you noted, Karen, varies depending on how many scripts a patient may have for having medication at school or at their family's house or a relative's house and so on. But at the end, because of the rates of asthma within Connecticut, declining performance for certain age bands and markets over the last 3 years, and the known disparities for patients with asthma, the Quality Council really wanted to make sure that there was a measure that was included focused on asthma. So that's why we ended up with that. Unfortunately, there aren't any better asthma measures available for which there is baseline performance. So that was a limitation that we unfortunately had to, it was a trade-off that we had to consider.
Yeah, I feel like I've said this before, so I apologize if I'm repeating myself, but I would urge this group to think about whether or not these measures really reflect the end goals, right? Quality measures are only as useful as the improvement that they're promoting. And I would say, for example, that asthma ED visits might be more meaningful measure of what needs to change in a system. And I understand the limitations of the principles and why that might not work for the Quality Council. But in terms of thinking about Medicaid systems transformation, without stratification, with measures that are supposed to be equity focused but exclude all but one limited race and then exclude 30% of people from that racial group, I have a hard time seeing how that's going to really benchmark for us how we're transforming our systems. And again, I know that sounds negative, and I'm not kind of poo-pooing the limitations or ignoring the principles of the council. I'm just saying that in the context of Medicaid, I think there's room for innovation and for really thinking about how to promote progress. And I'm not. I would hope that we can think beyond the strictures of this data set.
And I'll just add, Karen, that this does not limit the Transparency Council or Medicaid in terms of what we're able to either internally benchmark or do in terms of data transparency. This is really pertaining to the, the statewide Quality Council benchmarking process. So that does not preclude us from doing other things in addition, if that provides more context. Obviously, we want to align as much as possible. We also want to be realistic that I think we all know Medicaid and CHIP services, covers a historically marginalized community, and the things that we need to be looking at may be slightly different than for commercial insurance, though I think we probably all would like to see race ethnicity at least reported out for all of these things in the future.
And Brad, if you don't mind if I jump in too, I just wanted to say, Karen, we hear your feedback, and I actually absolutely appreciate that you keep bringing this up and pushing us to progress forward. And as DB said, that's definitely something we're going to look at in 2022, because it's something the Quality Council also brought up, that is there something we can do with homegrown measures, or should we change the principles to make sure we really are getting at equity? And I know it's a really big focus for them. So I encourage you to keep asking questions and keep giving us that feedback, because you're pushing us in the direction we want to go in. So thank you very much. And we're going to make sure that we keep looking into that.
Mm-hmm. We don't view it as negative.
Donna, I think we'll turn to Donna's hand up as well.
Yeah, one of the things I'm thinking, and I don't work with medical data quite so much, but when you're at the pharmacy or you're at, a walk-in, I see quite a number of our Medicaid recipients who are using those services. Would it be worthwhile considering putting in urgent care centers, or at least defining it a little bit more?
To clarify, do you mean having like a quality benchmark on use of urgent care services?
Yeah, because a lot of people are staying out of the emergency room these days, especially with the COVID. And, I could give you an example of my neighbor who recently had a couple of family members in for COVID related, and they didn't want to take the children to the hospital. So they took them to the walk-in or the urgent center to get treated for an asthma attack versus, going to the ED, because they were definitely afraid of going to the ED. And I see quite a few people, who are on Medicaid, because I hear them say, I have Husky, who are in the minute clinics at CVS. And that's just one example.
Mm-hmm. Yeah.
Thanks,
so,
or I was just gonna say, and Don, just for this purpose, is that we're just trying to kind of nail down like these specific measures, not necessarily expand it, but totally hear you. And I think internally we can always look at some of the utilization information.
Mm-hmm. And that's something we can also keep in mind for when we revisit the core measure set. I know the Quality Council did think about urgent care specifically for low back pain, but we can think about broader how we may be able to measure and assess urgent care use and ED use. Others, do you have any thoughts on the benchmark values for phase 1 measures before we move to phase 2?
Did advance the slide, but we can go back if necessary for sure.
Okay. Go ahead.
So I will jump in briefly, and I think this may be a point for the kind of transparency group as opposed to the Quality Council, but it does strike me that I think conceptually, for me at least, part of our goal here should be thinking about how to reduce the gap between Medicaid and non-Medicaid recipients, if we're truly thinking about equity here, right? That in some ways the secondary goal of ensuring equity within the Medicaid program is just to make sure that the program itself doesn't perpetuate population level inequities. Brad or others, are there ways in which we are either thinking about the gaps as a measure themselves, or ways in which we can think about benchmarks as relative to these other populations as a part of our dashboard / goal? Brad, I think you're on mute.
Oops, I'm on mute. I think, for example, the obesity equity measure, where you're measuring the gap between obesity rates between two different groups. I would honestly think that there's opportunity to think about this as an equity. That might be a homegrown component in the future for the Quality Council to think about, even though you use in the similar benchmarks that we're already using that everyone can measure, but then you do the comparison and say we need to close these gaps. And I think that's a huge opportunity, but obviously, whether we do it for a transparency process or Quality Council or both, I think that's a great point to probably bang it back around.
I think there's a few points that people have been touching on that really fall into what do we do as additional analyses beyond what is performance for Medicaid overall, what is performance for Connecticut overall, to drill down and find areas for improvement to really hit these benchmark values, and also to think about how do you improve performance in a way that's equitable. So doing additional drill downs to look at performance for Medicaid compared to commercial, to look at performance for certain races and ethnicities, language, disability status, that can really shed light on areas for growth and can help meet these benchmark values in a way that is fair and just. For the phase 2 quality benchmarks, as a reminder, these are measures that are implemented beginning in January of 2024. So there are no interim annual benchmark values for these 3 measures. It's only a 2025 value. Child and adolescent well-care visits, this measure changed significantly in 2020. And so we don't have any baseline data that's not severely impacted by COVID. And we wanted to make sure that when we were setting a 2025 benchmark value for hopefully a world that is far less impacted by COVID, that we were using baseline data that took that into consideration. So we will be revisiting a benchmark value for this measure in 2023 once we have 2022 data available. We've included follow-up after ED visit for mental illness and follow-up after hospitalization for mental illness as the 2 remaining quality benchmark measures for phase 2 for Medicaid. And here are the current values. I should have listed what current performance is for Medicaid. So for follow-up after ED visit, current performance is 50%, and the benchmark value is 65%. And then for follow-up after hospitalization for mental illness, current performance is 48%, and the benchmark value is 55%. The jumps between current performance and the benchmark is higher for these 2 measures than we saw for the other measures. That was something the Quality Council was conscious of, but they did note that the denominators for these measures typically are smaller. And so having improvements would have a larger impact on the actual rates because of the small denominator size. So I wanted to point that out too. So does the council have any feedback either on these phase 2 benchmark values or any of the phase 1 benchmark values that we reviewed on the previous slide?
And Karen?
Just a clarifying question. So these also are not going to be disaggregated by or stratified by race or ethnicity?
Not at this time. That is something that we'll be revisiting on an annual basis as we can get better capture of race ethnicity data. So hopefully by the time that we get to phase 2, we can disaggregate, but that is not something that we will commit to yet because we also don't want to publish performance based on bad data that may yield incorrect conclusions.
Meg?
Yeah, just a quick question, and maybe you covered this. When you're caring for dual eligibles, where does that fall in? Does that data also captured? Are you put into the Medicare or the Medicaid bucket for benchmarks?
That is a good question, and I don't think we've thought through the technical components of that yet. So we will think about that and get back to you.
Okay, thanks.
Yeah.
From a practical standpoint, Medicaid will struggle to capture some of this information just because we, just for dual eligibles. So the Medicare Advantage plans would likely be needing to provide a lot of the information just from a technical standpoint. Though we do get some of it, it's just we don't typically calculate those rates.
Okay.
Thanks. Can I ask a question? I may have missed this, but in terms of phase 1 and phase 2, and in some ways thinking about phase 3 here, is the goal to ultimately either incentivize improvement here, or I see the kind of benchmarks and the targets. Has there been any thought to how we get improvement?
Mm-hmm. So we are still in the process of developing our internal strategies for how to generate action. I will give you a sneak preview of the types of categories that we're thinking about, and we'll work with the Quality Council to develop these recommendations further and to start disseminating them into the world. One component that you noted, having these measures in contract and trying to incentivize movement towards the benchmark values is one strategy that we could use. There could also be some internal resources that are developed for best practices on how to, for example, control high blood pressure, how to talk to your patients about controlling HbA1c. There could be also some statewide public recognition type of programs to highlight people that are doing well from an absolute standpoint, but also that are really making strides and in improving performance on a year-over-year basis. So those are three categories of types of actions that we'll take. OHS is working with its Quality Council in 2022 to think through that further and create some more specificity around the 4 sentences I said out loud. But those are things that we're thinking about and that we'll further define in 2022.
Yeah, so for what it's worth, I think the measures themselves are important and really a step forward in many ways, but they do present or highlight some age-old challenges, right? Which is first, how do you distinguish good performance from higher or patients that are more likely to comply, right? And then secondly, how do you make sure that you don't actually incentivize some form of gaming of the system to the extent that you start linking this to payment and or stratification in ways that I think are even more challenging for outcome measures than they are for the kind of standard process measures. But I think that's just something that we have to grapple with, and it's probably a necessary advancement, but going to remain a challenge here.
Yeah, thanks for highlighting those. I think it'll be important to call those out explicitly when we're thinking about strategies.
So with the promise that we would be at an hour, a little bit over, but I think ultimately we actually got through a lot today. And one thing I do want to put on our radar is maybe there's, and I can talk with Kelly and Susan offline, is like, is there utility of transparency of this council being thinking about this, or should we be thinking about some internal benchmarks as well as part of some of this work? But I think we should keep that till the new year. We have a meeting scheduled for, I froze, hopefully you can hear me still, January, I believe, 20th. And we will hopefully have more to present at that point in time, 20th, to you, and actually maybe potentially a live dashboard that we can share and get more feedback on. But I think this might be an important part of this conversation as well. I think, we may want to, obviously, we want to work with our OHS colleagues, but also figure out what makes sense for Medicaid for benchmarking and other things. And we may want to discuss that as well. So I'd like to thank everybody for your commitment, bearing with us as we've gone through this year, and also for all of your feedback. And I am greatly looking forward to continue to working with you. And also thanks to Deepthi and Kelly for coming and presenting this and agreeing to kind of share this and allow us to provide feedback to them. With that, I think we will adjourn. Thanks, everybody.
Thanks, everybody.
Thanks.
Happy holidays.
Happy holidays, everyone.
All. Take care.